pre-record, but yet online live stream of our radio show for the week, The Heart of Innovation. And today we have Dr. Thomas Tu. He is the Chief Medical Officer for Inari Medical, and we're talking about blood clots. We are about to get underway in just a few moments, and we are now completely live streamed, and I'm going to start the stopwatch right now. Blood clots are a common occurrence that can have fatal consequences. However, they can be prevented by understanding the risk factors, recognizing the signs, and seeking prompt medical attention. This is an important topic, especially with World Thrombosis Day taking place annually on October 13th. And it's really personal for me as well, because back in 2012, my mom ended up with a pulmonary embolism, a clot, the doctor had told me, traveled from somewhere possibly behind her knee and ended up getting stuck in the arteries around her lungs or the veins around her lungs. We're going to get into the details of that and let Dr. Tu, who is here with us, go into the details and explain what may have happened there and possible treatment options that are now available that weren't back in 2012. So, gosh, I wish, Dr. John Phillips, that, we had, greater treatment options. All my mom was put on, I think at the time, was a little heparin drip, and she was sent home on Coumadin. But now I hear there's a lot more available for patients.
Yeah, I mean, if you want to talk about kind of a field and peripheral disease, so it's not arterial disease, now we're talking about the vein, so a different highway that has really kind of exploded with some new technology that realistically is pretty simple, right? But the devil's in the details, that now allows us to treat patients pretty quickly, removing the clot without exposing them, for the most part, to medications that can cause significant bleeding problems. And so Not everybody who has a blood clot in their leg or in their lungs needs an invasive procedure. But a lot, up until, last 5, 6, 7 years or so, prior to that, we were treating a lot of these folks with blood thinners, whether it's injectable through an IV and then sending them home with an oral medication. In some cases, we were using, we call them clot busting medicines. So real potent medications that break up the clot, but also have adverse side effects. Bleeding is one of them. And one of the most catastrophic things that can happen is bleeding into the brain, which, no one should die from a head bleed who has a blood clot in their leg or their lungs that's not, life-threatening. And so really looking forward to speaking with Dr. Tu about his role with a device company that really has kind of paved the way for us to treat blood clots, both in the lungs and in the legs, very quickly, safely, and without having to use these clot busting medicines. But also he's an interventional cardiologist. So certainly he clinically has seen these patients as well, as we all have. So it's going to be a great show.
And before we jump into the thick of it, how about a moment of inspiration?
Yes. So, preparing a quote for today, I thought, let's do a little research on the history of pulmonary embolism. Again, blood clots to the lungs and DVT, or deep venous thrombosis. So Rudolf Virchow was basically credited with discovering pulmonary emboli in the mid 1800s. He did autopsy studies and found, he was a pathologist, and he found blood clots in the patient's pulmonary arteries that had died. So, and another interesting tidbit is several years later, I forget the date exactly, but Trendelenburg was a surgeon who did the first kind of therapeutic or invasive procedure. He did open the patient's chest, open the pulmonary arteries, and 3 folks tried to pull out some clot. These patients were very sick and unfortunately died. This was before we had blood thinners and things of that nature. So despite the field being almost 200 years old, it's taken us, and Tom will tell us here shortly when exactly they started thinking about using basically tubes and suction to suck out the clot, but it's taken us a while to get to where we are. But one of the quotes that Virchow had, he had many of them. He liked to speak on faith and science and things of that nature, but I thought this was kind of cool because it sums up what we do in medicine, or what we try to do as medical professionals. And also, Kim, to your extent too, helping people with the weight of my heart and being an advocate. So he's quoted as saying, "First, it must be a pleasure to study the human body, the most miraculous masterpiece of nature, and to learn about the smallest vessel and the smallest fiber. But second, and most important, the medical profession gives the opportunity to alleviate the troubles of the body, ease the pain, to console a person who is in distress, and to lighten the hour of death, many a sufferer." So stew on that one for a little bit, but let's get into the meat of this conversation.
Wow. I see Dr. Thomas too smiling there. That resonates, doesn't it?
Yeah, certainly. John and Kim, thank you so much for inviting me to participate. Please call me Tom. John alluded to the fact that I wear two hats. I am an interventional cardiologist by training. I practiced medicine and procedural medicine for almost 20 years in Louisville, Kentucky. Now I wear a different hat. I'm a medical executive for a company that's developed tools to treat patients suffering from blood clots, particularly venous thromboembolism. And that quote that you cited really resonated with me. I think the idea of merging the study of the human body and the scientific principles required to innovate with the real ultimate mission of alleviating human suffering and providing comfort to those in need and perhaps prolonging life where possible, I think really resonates with me. And I'm so pleased to be able to talk about this very important disease state and some of the things that we're doing to try to help in that regard.
And I'm curious, what made you leave the practice and actually join industry?
Yeah, that's a great question. I started my medical career actually with the intention of being a molecular biologist. I was interested more on the scientific side of exploring the nature of biology, of human DNA. And I was introduced to the medical profession through medical research. And in medical school, I started taking care of patients as part of my training and realized that I actually enjoyed the delivery of healthcare and really being at the patient's side, using brains and hands to try to alleviate human suffering more so than I did the benchtop research. And I ended up training to be an interventional cardiologist, someone who cares a lot about cardiovascular medicine, not just heart, but also blood vessels. And in the practice of medicine for, as I said, almost 20 years, what I realized was, although we had made tremendous strides in treatment of patients with heart attack and with stroke, the top two leading cardiovascular killers, the third leading cardiovascular killer, which is pulmonary embolism, what we're going to be talking about today, was really pretty rudimentary. I probably spent a total of an hour learning about this disease state in medical school. I didn't have any specific training during my cardiology fellowship about this disease state, and really had a lot of misconceptions about this disease that certainly, I was faced with treating patients who ended up with this condition and realized we didn't have the tools nor the complete understanding of this disease state. And when offered the chance to really dive into learning more about this disease and helping patients directly with innovation and new tools, I really saw the opportunity to perhaps help patients at a very different scale than I was as a treating physician.
It's nice to actually have that opportunity because it's already frustrating for a patient to hear from a doctor that there's nothing we can do. But I would imagine that even more frustration on the doctor's part to not be able to do anything, to feel like their hands are tied, like there's nothing here for me.
Yeah, that what you say resonates with me. I can tell you offhand, I can think of 5 patients that I took care of that really highlighted the powerlessness that I had
Yeah.
as a physician to not fully understand and comprehend the nature of the disease state. And even if I knew what was going on, not having the tools at my disposal, whether they're medications or procedural tools to help solve what John has stated outright is, in theory, a very simple problem. And luckily, we were able to make some breakthroughs in the past several years that have really changed not just how we treat patients, but how we think about this disease altogether.
And we can't wait to hear all about that next, right here on the Heart of Innovation. So stay with us. Take us back in.
You ready?
Ready?
All right. 3, 2, 1. Welcome back, everybody, and thanks for joining us. We're continuing our conversation with Dr. Tom Tu, who is an executive at the company Inari, who they specialize in, quite frankly, sucking out blood clots. So, Tom, before we went to break, you shared some thoughts with the powerlessness that you had. Now we don't have that necessarily with some patients, and I can think of several patients too that we would see before we had the ability to, remove the clot without using clot busting medicine. These people needed something done. We didn't really have any tools for them because we couldn't give them the clot busting medicine, and they did okay. But, the long-term side effects of pulmonary emboli, blocking up the arteries going to the lungs and returning, getting the blood back, can be pretty profound. So let me, and I think of PE and DVT in the past as kind of the island of misfit toys. It's like, yeah, it's a diagnosis, and okay, we put them on some heparin or Lovenox, and then we switch them off to another medication. So tell me, at what point did you join Inari, when, and why? And then how did you guys start to develop, again, a very simple device that works so well?
Thanks for the question, John. So imagine me being a fairly young interventional cardiologist practicing in my newly adopted community and treating patients that I was trained to deal with, such as heart attack patients, patients with peripheral arterial disease, and then getting a phone call from the chief of our ICU. I still remember this day, 4 a.m. I wasn't even on call. And the ICU had said, "Hey, Tom, I wonder if you could help me with this patient who's dying of a pulmonary embolism." And I said, "Well, that's not really a disease that I'm, trained to treat." And he said, "Yeah, but we've tried everything else. We've tried the clot busting medicine. We've tried anticoagulation. It's a young healthcare provider, and he's literally dying. I heard you can, you're a whiz with catheters. Can you do something for this patient?" And I said, "Wow. Here I am faced with a problem I've never really dealt with before, but yeah, I understand the theory. Maybe we can do something for this person." And we have a saying around here: if you don't know what to do, you do what you know. And so I did those things. I did a procedure to take pictures and measured pressures and saw the clot and used various tools that were really optimized for the heart to treat blood clots in the lung. And I don't know if I did anything good, but after an hour or two of work, he seemed to do better. And literally the next day, he was off of his life support and ended up leaving the hospital and did well. And I still get birthday cards from his mother thanking me for the work there. And my eyes were open to this whole new disease state that I was not really involved in, where potentially we could help. Now, imagine a couple years later, a very similar story, a young man who was in his 20s. Literally, the only reason why he was in the hospital is he fell off a curb or something and broke his ankle and was in a cast for 6 weeks. Healthy young guy, but now came into the hospital with this huge blood clot, and it was filling his lungs. And we tried all the usual treatments, including the clot busting medicines. And I still remember saying, "Yes, we can try to help you, sir." And he said, "Whatever you do, please keep me alive, because I've got to live for my, newborn child and my wife." And I said, "Well, sir, we're going to do everything we can." And I don't know if you've ever been sick in the hospital and your life is on the line, and the doctor says, "We're going to do everything we can," rather than, "Oh, you're going to be fine." That's usually a sign, right? It's a sign that we don't think it's going to be a good outcome. And sure enough, despite everything we tried, I couldn't save his life. And that feeling of powerlessness, to know that it's a problem that I understand, fairly well, and yet didn't have the tools to treat, really left a mark on me. A few years later, a colleague of mine who was in the medical technology industry came by my town and said, "Hey, I'm working for this new company that's trying to develop tools for pulmonary embolism, this problem." And I saw it was a first generation device. It was like Tinker Toys, and it was sort of not ready to be used in human beings yet, but it had a lot of the elements of things that my career had been based on, such as sucking out blood clots, such as large bore access, mechanical tools to disrupt clot. And I said, wow, there's a chance this could work. And going from that stage of concept to then actually working on the device to get it to be safely used in human beings, to then do the clinical studies, to get FDA approval for that device, and then, kind of making the iterations on it. We started with one concept and shifted to a very different concept, thanks to some of the observations I made actually, with the device in clinical trials. It was really an eye-opening experience. And like I said, I'd never intended to work for a medical device company, but seeing a disease state that I knew the impact of and how commonly it occurred across the world, and to see something new. I mean, I still remember the day where, it worked, and it worked so well, and my eyes got as big as saucers, and I knew that this was something that was really going to change the world. And the patient knew it as well, because they were literally complaining that they were going to die. And then all of a sudden they said, "Doc, what did you do? I feel back to normal again." And they knew something was up, and the nurses could see right away. And that was a very powerful day for me as a physician, as well as something that drove, me into a career that I'd never contemplated.
And that's what's interesting, is that there is this with PEs in particular, and sucking out that clot, there is that instant gratification. There is that instant relief.
Well,
Yeah.
I mean, it's so for the longest time, well, a couple of points. Number one, to Tom's point, these are often young patients who were in the hospital, bedridden, whatever. And no, you shouldn't get a blood clot in the hospital. I mean, that's like the number one, in my mind, like the thing that we should be able to fix, but yet we still have that happen. But these are young people. A lot of the folks that we see with peripheral arterial disease are older and have a lot of comorbidities, health problems. These are young folks, and
my mom was very young.
Yeah, and they die. And so the ability to treat the patient quickly and safely and effectively, it's like, as an interventional cardiologist, it's like treating a patient with an acute myocardial infarction. You open that artery and then they feel better. You clean out the clot, and you don't have to clean everything out. You get the big chunks out, and folks feel better instantaneously. Tom, let me ask you this. Because for the longest time, it was acceptable to just put people on anticoagulation and send them home with blood clots, both in the legs and in the lungs. So you guys shifted the paradigm. It was kind of the tectonic plates moved pretty significantly, and there was an earthquake, because every company now is chasing what you guys did for the, in the PE space and the DVT space. But you probably had a lot of folks that were like, you know what, we don't really need to treat these people. They're going to do okay. Yeah, they're on a little oxygen. Maybe they're a little short of breath. Why are you sticking a big garden hose up in their arteries and trying to suck out this clot? It's something that you really need to do, because we struggle with that too when we interact with other physicians in different specialties in our health system. And I don't want to say you got to change them into a believer or not a believer in the treatment, but how did you guys get over that hurdle?
Yeah, well, it's a battle we still fight. And I will say that a lot of it has to do with what you're taught in medical school. Many physicians learn their point of view about treatment of disease, and then once they finish their training, that pretty much shuts off. And it's, the practice of medicine, the delivery of healthcare, not, kind of staying up to date on new ways of thinking. And, I I hearken back to the time as a young cardiologist where we debated the value of doing intervention for heart attacks, right? You probably don't remember that, John, but there's a time where we said, yeah, we don't really need to treat these heart attacks, right? The medicines work fine, and only in very specific circumstances should we do intervention. And it took a lot of very courageous physicians, courageous patients to be involved in clinical studies to generate the data that proved that, yes, it was the right thing, and it was the right thing for a broad population of patients. And now we're at the point where the question for heart attack is more, do we have systems of care so that everybody has access to this kind of technology and this kind of care 24/7, no matter where they live, right? We're nowhere near that in venous thromboembolism. I think the vast majority of people who treat patients with venous thromboembolism are not aware of other treatment patterns, right? They only know anticoagulation. And so their natural belief system is, well, they all do fine. Patients do fine. Well, you lived, what more do you want, right? I don't know, Kim, about your mom and how she did with her pulmonary embolism, but if she survived her event, I bet you her treatment physicians probably said, oh, job well done. See, we gave her the medicine and she survived. What more do you want? It's quite possible, now that we've studied this, that we find, oh, well, even if you survive, you're limited by trouble breathing. The rate of post-traumatic stress disorder after survival of a VTE event is like 90%. There are people who never feel the same afterwards. Can we improve not only their length of life with intervention, which I think there's an obviousness to that now, but also can we improve their quality of life? For those patients who maybe wouldn't have died from their pulmonary embolism anyway, does removing the clot, restoring the anatomy back to normal with a simple procedure, reduce the chance that they're going to suffer from these long-term consequences? And that's where clinical data really is going to help drive this. And, I'm very proud to work for a company that's committing lots of resources, not just to making products and selling them, but then to plow those resources back into clinical data. We're spending over $30 million this year alone in generating clinical data to help inform the scientific and medical communities about the value of this kind of intervention.
And coming up right here on the Heart of Innovation, we'll have more with Dr. Thomas Tu with Inari Medical, so stay with us. Perfect. It would be great to go back to, we're in segment 3?
Yep.
So it would be great to go back, where I'm getting some questions about the formation of a blood clot versus thrombus, and what are the indications for each of the different treatments, and what's the difference between one that, it develops behind the leg, but then it goes to the lungs and that kind of thing. So
yeah, love
sure.
to talk about that.
We'll do it.
Great. Ready?
3, 2, 1. Welcome back, everybody. We are continuing a really fascinating conversation, in my opinion, and I think Kim would agree with Tom Tu from Inari Medical. And we've gotten some questions regarding blood clot formation, right? And I quoted Virchow, who he has a triangle about the kind of the theory about why blood clots occur with inflammation and the blood, not flowing well, and then some type of an event that causes the body to want to have the cells clot together. So, Tom, give us your kind of layman's description of what a blood clot is. Why do they occur? Why do they occur mainly in the legs and not the arms? And what do you know about some that want to go to the lungs and some that just want to stay put?
Yeah, that's a great question. So the disease state we call venous thromboembolism, or VTE. This is blood clot forming in the veins of the body. And as you pointed to, Virchow's triad points to 3 groups of kind of contributory factors. One is vessel injury. So a blood vessel has a lining to it. The blood plays along very nicely, flowing through these tubes. But if the tube becomes injured, there's an activation of the clotting cascade where that blood now wants to clot, presumably to try to prevent you from leaking blood out of a blood vessel, right? There's an evolutionary advantage to not bleeding to death if you injure a blood vessel. The second contributor is hypercoagulability. So if your blood, for whatever reason, oftentimes now genetics, can increase your tendency to clot, sometimes inflammation, other kinds of infections or cancer can cause your blood to be more clotty. And then lastly is what we call stasis. So if your vessels are compressed, or if you're immobile for a length of time, your blood is not flowing as freely, and that stagnant blood tends to clot as well. So for those three reasons, you can imagine a whole host of patients, young and old, healthy and sick, all being potentially at risk for forming blood clot in the vessels of the leg. The leg is where you have a lot of the venous blood, and that's an area of compression. You can imagine being on a long plane flight with your legs crossed. You can imagine some patients being born with certain anatomical features that have inherent compression in their legs. But when the blood clot forms, because the blood vessel is so large, there's actually kind of flow around the blood clot. You're not aware when you form this. In fact, oftentimes you have a wall adherent clot that can be present for days or even weeks before you're aware of it. And as that clot continues to grow, growing towards the center of the vessel and growing up and down the leg, you form what are called collaterals. Your body's able to form bypass channels around the clot, and you still may not be symptomatic. And it's only when the clot grows large enough that it overcomes the body's ability to grow, bypass channels, that you might develop pain or swelling in the leg as a first common symptom. Many patients will have that blood clot kind of loosen and break free, traveling through the circulation and eventually lodging in the lungs as the first symptom that they had a blood clot. So these are things that we're just starting to learn about the time course of these events. If somebody has swelling today, that's possible that their blood clot started weeks ago. If somebody has a blood clot that traveled to the lung, and you say, oh, I felt it travel through my heart and into my lungs, that clot may be an evolution for several days, if not weeks, before that event. The reason why the timing is important is because the nature of the stuff that's in the blood clot evolves over time. When blood first clots, we're talking about venous clots now, it's this kind of what I call blood jello, right? You have stuff dissolved in the bloodstream that is liquid. And when it gets activated, it forms these polymer cross-links, just like how you make jello, right? It's a liquid that turns into a hydrogel. And that's the first thing that forms blood clots. That's something that can be inhibited by anticoagulants, such as heparin or Coumadin, or now the NOACs. And it could be something that could be actively degraded by the so-called clot busters, right? That's the effect of TPA and other kinds of drugs. But over time, over days and weeks, that blood jello is replaced by fibrous tissue, collagen, connective tissue, infiltrating fibroblasts and things like that. Now it becomes more like a scar tissue than it is a clot. And all the anticoagulants in the world, all of the clot busters in the world won't break that stuff down. That stuff needs to be mechanically removed or incorporated into the wall for the body to form a channel again. And that's all new observations that have come out of the fact that we can extract these clots and examine them under the microscope and in the lab to really understand what we're dealing with.
So, Tom, can I ask you to explain to our listeners the difference between a blood clot in the veins versus the arteries, and why do you get more clots in the veins than, yes, we get blood clots in the heart. That's your heart attack. But for the most part, people aren't having a lot of blood clots in their arteries of the legs. Why the difference?
Yeah, that's a great distinction to make, especially being so close to World Thrombosis Day and interest in clots, right? And I know this audience has a particular interest in peripheral arterial disease, and that's a very important disease state. But there's some important similarities and differences between artery disease and vein disease. So you're familiar with peripheral arterial disease, similar to coronary artery disease, blockages of the heart. There's some narrowing of the pathways, and then maybe some subsequent blood clot formation that's part of the final pathway that occludes these vessels. That kind of clot is very small. If you took out a blood clot that's responsible for a heart attack or an acutely blocked leg, it might be, tens of milligrams, might be the size of a rice grain. That is life-threatening clot if it's in a certain location, right? If it's in your heart, you could have a major heart attack. If it's in your brain, you could have a major stroke. You could lose part of your leg if it's in your lower extremity. Blood clots in the venous system are different in that they're much larger. They're 1,000 times the size, the clot. So The kind of clot I'm talking about in a DVT is like handfuls of clot, hundreds of grams of clot.
Why is that?
It's
Wow.
because the vessels are so much bigger,
Yeah.
and the clot can form over time because the body can form collateral channels around it. So when you clot off your leg in the vein, you may not have that bad of a set of symptoms that drives you to attention. It may be an evolution for days or weeks. And so that little bit of swelling in the leg could be that first sign that, that kind of cramping in the leg when you walk. It could be arterial disease, but it could also be the sign of a DVT. And if you don't catch it early, that clot may be very, very extensive by the time it presents.
Wow, that's incredible. I see a lot of folks that are chiming in about that, because it is really fascinating. When you have clots in the veins, clots in the arteries, and when the doctors talk to a lot of our patients, they don't differentiate between the clots in the arteries and the clots in the veins. And I even have patients that come to me and they think that peripheral artery disease is actually their veins. Because their doctor said, well, I think that they'll only understand that there's just one type of vessel going through, as we'll just call them the veins. It'll be much easier. But I think it's really important to empower the patient to differentiate the two, especially for the reasons that you were discussing, because there are different treatment options for it as well.
Kim, you're so right. And, I know a lot of the mission for this organization and the people on this call is to highlight the sort of under recognition of peripheral arterial disease. But I'll tell you, venous disease is even far less recognized. And you were very generous to say, well, maybe the doctors are simplifying it for patients. But the truth is, many doctors don't really understand this condition as well. I didn't understand this condition as well. And I, am somebody who prided himself on being a very educated interventional cardiologist. It just wasn't something that there was a lot of knowledge about. And so we were taught very limited things about blood clots in the veins, blood clots that travel to the lungs. I like to tell it this way. We know so much about heart disease and stroke now that if you had a heart attack, you would expect to go see a heart doctor and have a heart procedure and take heart medicines. And there's a follow-up that would be very developed, and you would have expectations about the expertise there, right? The same is true for a brain attack, right? You would see a brain doctor and have a brain procedure and follow up with a brain doctor. There is no such thing as a pulmonary embolism doctor or a DVT doctor. It could be a vascular surgeon, it could be a vascular medicine doctor, an interventional cardiologist, radiologist, a general practitioner, a hospitalist, an ER doctor. All of these different types of doctors, quote unquote, treat your blood clot because there's very little known about it. And I think one of the things that I'm hoping to really inspire is the development of a set of expert physicians who can really have the knowledge base about modern treatments for this disease.
Tom, you bring up some excellent points. We're coming up on a break, so stay with us. And when we come back, we're going to continue this conversation with Dr. Tu.
Perfect. Take us back. Last, think about probably 9 minutes, probably 8 minutes on this one, because we were over on a couple. So 8 minutes on this one.
All right. 3, 2, 1. Welcome back, everybody. So Tom, before we went to break, you were speaking to not only the lack of awareness that exists for patients about DVT PE, but also within the community, the medical community. So that's a pretty big boulder to push up a hill, because there are people to this day who don't believe that we should be treating some of these folks. Where you have seen it, I've seen it. I mean, I became a believer when we had a patient who, a young man, I'll tell the story because it still gives me goosebumps, but he was dropping his children off at school, and he's in the drop off lane or whatever. And he drops his kids off and he says, I don't feel good. And there was a teacher who looked at him and said, you don't look good. You need to maybe go home. She followed him home and he collapsed. So he lost consciousness. She called the squad, rushed him to our hospital. We figured out pretty quickly that he had a massive pulmonary embolism, and this was during business hours. And so myself and a good friend of ours, Mitch Silver, we brought him to the catheterization suite, and literally the two of us, within probably 10 minutes, we had your device in his pulmonary artery, sucking out the clot, and the guy walked out the next day, which really was amazing. But there are still people that don't necessarily think we should be, and that was a little bit of extreme, but there's a lot of folks that push back. So you want to raise awareness and educate folks. So how do you guys go about that? Our show's about innovation. How are you innovating? Yes, with your devices, but also with the people that use them. And my follow-up question is, do you said you wanted to create a group of specialized interventionalists. Do you think everybody should be using your devices to treat folks with pulmonary embolism or DVT?
Those are great questions, John. So a couple of things. One is our company believes in what we call the 4 pillars. These are the 4 different ways that we think we can best influence patient care. One is in training and education, right? There's a huge unmet need here for both interventional physicians, people who use our devices to treat patients, to train them to use them in the best way possible to get the best possible outcomes for patients, but also to train the broader group of physicians who interact with these patients, who make the diagnosis, right? The emergency room is a great place to start. This is where 70% of patients with pulmonary embolism and DVT present, and helping those emergency room physicians understand there's more options for care. Second pillar is clinical research. I talked already about the amount of effort that we're putting into generating high-level clinical data to help sway opinion from some of the folks who are a little more skeptical about new ways of treatment. Of course, data will help that quite a bit. Third is in research and development. We, of course, have developed groundbreaking devices, but we continue to iterate them, right? Because the better and better we can get outcomes for patients, the more likely we can help people. And the last one is the one I'd like to emphasize. That's in program building, right? The mission for our program building is not to make sure everybody gets our procedure, right? That's not really the point. The point is to make sure that all patients who develop venous thromboembolism have the opportunity to consult with an expert who understands the disease state, right? So rather than the person who's the last time they thought about this disease was 30 years ago in medical school and haven't really kept up on modern therapies, that they go to somebody who is actually involved in kind of the most up-to-date research. Just like how if you had a heart attack these days, you wouldn't be satisfied being treated by anybody other than a cardiologist for that disease state and a stroke specialist for stroke. Why wouldn't you want a VTE specialist being involved in the care of that disease?
Now, so part of what you guys are doing at Inari is going out to primary, if I understand it correctly, the primary care physicians and ER doctors and educating them. Do you find that some people that leaves an unpleasant taste in their mouth? Like, should industry really be interacting with these specialists or not? I mean, obviously you guys do it, but what are your thoughts on that if you get pushback?
It's a coalition of the willing. We are very transparent in what we're doing, right? We talk about the disease state. We talk about what we know, what we don't know, and our beliefs about what our devices can do. But when we interact with emergency room physicians, I would say the vast majority of them are very thankful to hear new ways of thinking and new scientific discoveries. Some of them might be interested in our device and want to learn more about it. Some of them just say, wow, thanks a lot. I learned a lot. Is there anybody in my hospital that I can count on as a vascular specialist that I might want to include in the care of my patients when I make this diagnosis, right? And just that level of interaction can really help patients, right? So that they get a higher level of expertise involved in what turns out to be a very complex disease and one that has new treatment options.
Yeah.
One of my greatest frustrations that I have in running a patient advocacy organization and working with peripheral artery disease in particular, but now I'm seeing it also as you're speaking with pulmonary embolisms and other issues of the venous system, is I just don't understand that doctors get into practicing medicine because it's about practicing medicine. And yet, when you have these new innovative tools and techniques that could give them, at least an option to try to save a patient's life or a patient's limb, if all else has failed, like, Why not try? And yet a doctor will say to us, there's not enough evidence. Well, how do you create evidence? Someone's got to try it. And I love the story that you shared in the beginning, which speaks volumes to your character. And I know this is true also for Dr. John Phillips and his cases as well, is, you try things, you're willing to use what you know and apply it, even if it is in a different way. And I don't know about,
no, Kim,
go ahead.
that's an excellent point. I'll say that because we treat so many patients with pulmonary embolism and DVT in our hospital, but we don't treat everybody. And the thing that makes you a good physician, because to Tom's point, when I graduated fellowship and came to work, I didn't treat pulmonary embolism. We didn't treat DVTs. We anticoagulated, but I mean, that was it. And if you're really sick, you got lytics or clot busting agents. So number one, you have to have an open mindset to adapt a new technology, but it's more than that. It's a paradigm shift, right? I mean, it's thinking differently about something. But what also happens, in my opinion, and Tom, you can comment on this as well, you get a lot of, there's the adage, you have to kiss a lot of frogs to get the prince or princess. You see a lot of consults for things that don't need anything, but that's where you learn, like, okay, I think I should treat this patient, but I don't necessarily have to treat with an invasive procedure, but I don't necessarily have to treat that patient. And there's other technologies out there that we can use as well. But you're thinking outside the box, you're doing what's right for the patient, and you're learning. We're continuing, in my opinion, to evolve how we treat patients, who needs treatment, what type of treatment. And that's what's kind of fun about it. I don't want people to think that everybody needs treatment for a pulmonary embolism and everybody needs treatment for a DVT. But to Tom's point, now there's an opportunity for those who need it to get evaluated. So.
And coming up next, right here on the Heart of Innovation, we're going to hear Tom's response and his final thoughts next. So stay with us. And so we have about 4 to 5 minutes here. So we'll keep the answers quick, and then, John, bring him back so he has a chance to respond.
All right. Okay. I just threw, I sorry, I get like.
No, I love that, because I did too. We're very passionate about this, Tom.
Yeah, I love it.
But we'd love to, in the end, would love to cover 2 quick things, Joe, keep your response kind of concise. But then I'd like to get to the 2 final points. One, is this something that patients should be talking to their doctors, especially ones that are listening now that already have some sort of vascular issue that is a predisposition for having blood clots or putting them more at risk? So should they be starting now to vet their doctors and to find that go-to in their hospital system? And what do they ask? Number 2, quick signs and symptoms for a blood clot. And so we have to do all of this and more in less than 5 minutes.
I think we can do it.
All right, we can do it. All right. Ready? 3, 2, 1. Welcome back, everybody. We have about 5 minutes left of the show. So Tom, I was on my soapbox about the whole education and patient awareness and things of that nature. So do you have any thoughts on my diatribe?
Yeah, it's a culture shift, right? And like any other population, physicians are a group of individuals who have varying opinions. And, it's what I realize being on this side of the fence now is that it's an incredible amount of effort to get the majority of people to start shifting their belief system, but they will over time, right? What convinces people is stories, their personal experience, seeing the effects that new therapies have, like your patient that you described, John. I think telling that story really has a meaningful impact to physicians. And then, of course, clinical data and that kind of thing is also very valuable. What I would say from the patient perspective, right? I think bringing it back to the patient is critical. Many of your audience probably wonders, do I have a blood clot? What kind of things should I worry about? I think the signs and symptoms of a blood clot in the leg are somewhat nonspecific. And the good news is the testing is pretty straightforward to make the diagnosis. If you have swelling in one leg and not the other, that's oftentimes a sign. If you have cramping pain, in the hip or behind the knee, along with swelling, that certainly could be a sign. And certainly, kind of an abrupt discoloration of your leg. I've seen patients who they just look down and their leg turned purple. Yeah, that is something where, seeking medical advice and diagnosis could be very useful. The test for a DVT, a blood clot in the leg, is oftentimes an ultrasound, which is a non-invasive, no-risk kind of procedure, so can be very useful. Blood clot in the lung is more serious, more urgent. That oftentimes will show itself through trouble breathing. People sometimes say they almost passed out, or they feel very dizzy, they get sick all of a sudden, and then notice their heart is beating fast and they can't breathe. If you can't finish a sentence without panting or getting out of breath, and that happened all of a sudden, that certainly could be a blood clot. To diagnose that in the emergency room, it's really a CAT scan is the modern way to do that. It's a special kind of CT scan. It's called a CT angiogram of the chest. You probably don't need to know that by name. The physicians taking care of you can do a history and physical, do some simple blood tests, and kind of make a decision. Do you need a CT scan to diagnose blood clots or not? Where I think patients should focus is more what happens when I do have that diagnosis, right? Am I getting the right kind of care? Am I getting the right kind of advice? Many physicians, like I said, aren't fully aware of the extent of this disease state. And I think a simple question like, who is the vascular specialist here that has expertise in blood clots? Do you have doctors who do these kinds of procedures? Not that you need the procedure per se, but generally those that have the ability to provide that care are much more invested in the disease state and therefore are more knowledgeable about what the right treatment care should be. So I do think patient advocacy, advocating for yourself really can make a difference in this disease.
And so when you're talking about, do they treat it? Well, of course, they're going to say, yeah, we treat it. We treat everything. No problem. Just come to us. We have great doctors here. We're a big name facility. But what specifically can they ask for? We train our patients, empower them with all of the treatment options to discuss with their doctors. Do they just use medicine? Do they use clot busting medicine? Do they use tools that suck out the clot? I would imagine that would be something that would be critical to determine, well, is this a place that might have the most advanced treatment options for me in case that I need them?
Yeah. I mean, sorry, Tom, I would just say real quickly, you have the blood clot in the leg. You probably want to ask some questions. Where's the clot? Is there a vascular specialist that I could see? In the lungs, I mean, I don't know too many patients that are going to be asking for treatment because they're getting treatment, they're getting evaluated. And it's really, that's where the ER physician plays a role in knowing of what should be offered, what could be offered for the patient.
Yeah. Real quick, I just want to offer your viewers
ahead of time. It's nice to, be prepared just in case.
Yeah. I want to leave your viewers with 2 quick words that might help them find care that could be very useful. If you know the term thrombectomy, that's removal of the blood clot. And if you know the term PERT, which is PE response team, those are oftentimes markers of centers that have developed a little more expertise in how they think and approach this disease.
Thank you so much, Dr. Thomas, too. We really appreciate you joining us. And if anyone wants to review the show again, they can go to theheartofinnovation.org. Have a great weekend, everyone.
Thanks, everybody.
Fantastic. So we are going to go ahead and go into our after show. Tom, you offered to stay for a few more minutes.
Yes, I'm happy to.